of the Massachusetts universal system, which, as you know, was in some ways the benchmark or the template for Obamacare. I understand Obamacare has been in the news a little bit lately?
A little bit,
A little bit. You've probably read one or two stories in the paper about this. There's a lot that we'd like to discuss with Dr. De La Torre, but I think we might as well go to the one question I suppose is on everyone's mind right now. We have seen this train wreck of a rollout, I think would not be an unfair way of describing Obamacare. Whether you're for it or against it, clearly the process for the last few months hasn't gone very well. Ralph, you've been involved in healthcare for a long time. As a heart surgeon initially, you're now running a large hospital chain. You've watched what's happened with Obamacare. Is this a glitch that we won't be discussing 6 months from now, or is it possible that expectations have been so badly damaged that the system may not be salvageable? What do you think?
Well, it's hard to predict. I think that to expect anything like this program to roll out, or even healthcare reform to roll out and have the original legislation be all-encompassing and have all the solutions is unreasonable. It was going to need modifications, and it's going to continuously need modifications. The real kernel of the question is that revolutions don't happen when bad situations exist. They happen when reality and expectations don't converge. So the question here is, there is an expectation, and if reality lags it, are people going to revolt against it? So this, in many ways, as we were talking earlier, chits were used up in this rollout. So there was an expectation that, yes, it'll be rough and they'll need fixes, but it's going to be pretty good. This used up a lot of those chits, and if it goes flawlessly from here on out, then it'll be fine. But I think that every time that something bad happens, it's going to call it into question. It's going to be magnified more and more. So I think a little bit of it depends on how bad it goes from here on out as to whether or not people rebel against it.
So in a sense, you're saying that the margin of error has been reduced. Had this gone well, people might have tolerated some glitches down the road, but the president and the supporters of the program have really used up a lot, or maybe all of their goodwill at this point, haven't they?
Well, my mom always used to say, God gave us all a certain amount of grace units, don't use them all up at once. So I think that there's been a lot of grace units used up in this.
Okay, well, we'll see. The program supposedly had some major fixes as of December 1st, and when we were discussing earlier, the program has said that it can now accommodate up to 50,000 people going on the website to sign up for health care, which may sound like quite a bit, but you were saying from your experience, in fact, that shouldn't have been a very tough ask to begin with, should it?
No, it really shouldn't have. And if you think of large companies, in America and abroad that do benefit enrollment every year, and you have places like Walmart with, 7-figure employees that are able to sign up and get health care and get all their benefits signed up, they should have been able to accommodate that. And I think, in retrospect, one of the errors that was committed was not to rely more heavily on American industry that knows how to do this, the Uniteds of the world, the Optums of the world, that kind of do this all the time. There was no need to really reinvent the wheel.
Yep. So maybe a little bit more private sector involvement might have helped this process. Let's leave the particular rollout of Obamacare aside for a moment and just talk a little bit more about some of the underlying issues that it was meant to address. As you well know, there have been 2 or 3 features of healthcare in the U.S. that have been unusual, that have made things very costly here. And one, of course, was the fee-for-service program, where hospitals like yours traditionally have had an incentive to provide as much care as possible so they could charge as much and provide as many fees, which is one of the reasons why we have the highest healthcare costs in the world. And then interestingly, the prices that we all pay for healthcare, most of us really have no idea what we're paying, do we, when we're paying it? It's only when the bill comes later and we realize it. So Obamacare and the other changes that we've seen, Ralph, over the last few years, they've been designed, haven't they, to try to address the volume issue, too many services, perhaps at too high a cost, and then the question of transparency on prices. Your company, Steward, has been involved in this. What's working well about trying to contain the fee-for-service issue and the transparency? I mean, is anything working there? Is that something we can fix, or is it a part of the system that's just not resolvable in the kind of network we have in the U.S.?
No, I think it's very much resolvable. In Massachusetts, Steward is almost exclusively, on the commercial side, exclusively global payment or some model of risk capitated. So we do almost no fee-for-service.
Really? Okay.
We're almost completely contained within a capitated environment or risk environment within our contracts. And I think that does work. I think it aligns incentives, it forces integration, it forces better care and coordination. The other one is a little bit more difficult, transparency, because most consumers don't care what it costs. They've almost prepaid up front for it. And we see this a lot in the benefit design and whether co-pays dramatically decrease healthcare costs. And I think they decrease utilization a little bit, but they don't really get patients or prospective patients to choose one program versus another based on cost. Just they might push back or hold back a little bit on utilization. And things like defined contribution as opposed to paying a fixed percentage of a premium as an employer would actually accentuate the price difference in different programs and get the consumer to actually understand, if I pick this program, it's going to cost an extra $1,000. If I take this, it's going to cost an extra $5,000, rather than masking it by a percent of premium contribution by the employer.
So from the consumer standpoint, then, do you think consumers have enough visibility on? They have some visibility, of course, on the insurance. People know perhaps how much is being taken out of their paycheck every month as well, too. But do people have visibility on the actual costs of the services themselves?
So I guess what I'm saying is people don't care, right? I mean, they've already paid the premium. They've already paid it out of their paycheck. So they don't necessarily care if I go to hospital A or hospital B, it costs $100 more. Mm-hmm. It doesn't cost me $100 more, it just costs $100 more. The point I was making is if you think about it, if it costs $2,000 more a year to have one insurance versus another, but your employer is paying 80% of the premium, yes, right? Then you're only picking up $400. $400 spread over 12 months doesn't seem all that much. But if all of a sudden your employer says, we're going to pay $8,000, and this other plan is $10,000, and if you want that other plan, then you got to pick up the extra $2,000. If you want this plan, you get it for free. That will accentuate the price difference, and then the employee who's choosing it, the prospective patient, says, wow, is that worth an extra $2,000 to me? Sure. That will have more effect on curbing and being transparent. Because I think that, and at the end of the day, you can't forget that in America, 60 to 65% of healthcare, at least where we're at, is provided by Medicare, Medicaid, right? And that's just a different animal, which very little has been done to address. The payment reform, the utilization reform, everything that we've done in Massachusetts to try to impact cost doesn't apply to the government. I mean, here we are in 2013 in Medicare, you don't even need to pick a primary care doctor. There's not even that requirement. I mean, that's just the intersection of good medicine with good fiscal policy. And I think Medicare needs to kind of step up and acknowledge its role in changing healthcare costs.
You said something that's important, and I want you to just dwell on that a little bit more. 60 to 65% of all healthcare spending in the U.S. is tied into government programs, Medicare, yes, and Medicaid.
Yes.
Which is, and I thought we had a private healthcare system in the U.S.
Yeah, well. Yeah. I mean, it might even be a little more than that when you put in Medicare, Medicaid, the municipalities, all the municipal government employees, and the Department of Defense. When you look at how much is actually paid by government, it's an astounding number. Mm-hmm. And so we dwell a lot on the commercial markets, but at the end of the day, it's really what government is paying, what we as taxpayers. I think the disconnect is we view Medicare, and I'll use it as a surrogate for Medicaid, as an entitlement. And it's not. It's health insurance. It's not an entitlement. It's health insurance. And we need to start thinking of it as health insurance. Because when you start thinking about it as health insurance, all of a sudden you start saying, well, you really should have a primary care doctor. And we really should put in these kind of disease management platforms. So I think we need to change the way that we think about it.
But of course, politically at least, if you're in Washington, it is considered an entitlement, isn't it? In the same way that Social Security is. But you're saying that's part of the problem. If we look at it as insurance and treat it as insurance instead of as a political entitlement, that could be the kind of sort of fundamental change in the way we look at it that's required.
So, I'm sorry, I didn't understand. Is the question is whether Washington's part of the problem or the entitlement's part of the problem?
Well, I think probably, certainly, Washington has encouraged people to think of this as an entitlement.
Yes.
And when you have seniors that are retiring, they certainly would look upon health care, I think, as an entitlement, in the same way that they would look at Social Security as well, too.
But it's a problem, right? Because we're not communicating well. We're not educating well. It's if you're 86 years old and you have a headache, why would you pick up a phone book and go see a neurosurgeon? I mean, this happened to my mom. She calls me the other day and she's got this horrible headache and she's going to go see a neurologist or a neurosurgeon. And I had one simple question. Have you been talking to my brother? And she goes, yes. I go, well, that's why you've got a headache. So, I mean, I think that interjecting a primary care into the flow, giving them somebody, even if the primary care doesn't act as a gatekeeper, it's a dramatic difference. And I'll prove it out for you.
Sure.
As you know, we're one of the ACO pioneers, which is Medicare's.
So talk about what an ACO is.
Okay.
Accountable Care Organization, but what does that mean, Doctor?
So all an accountable care organization really is an integrated platform. So we integrate everything into one vertical unit. So it's the hospitals, the doctors, the care management, the disease management, and the financial responsibility to provide all those things. It's coordinated care.
But this is something that was set up by the government to try to encourage more coordination of care and lower prices, or not?
Well, yeah, but if you ask me, it's a little bit like doing a study as to whether cars do better with round wheels or square wheels. We kind of know the answer, right? I mean, coordinated care is always better. Care that goes through, disease management is going to be better. So along those lines, but that's what it was. Medicare decided to create a study. Now remember, a lot of what they're studying was mandated in Massachusetts already. So we kind of know the answer. But when you look in our population of Medicare patients, and you look at the cost per patient, and you match them demographically, comorbidities, socioeconomically, the one variable that most determines the cost is whether or not they have a primary care doctor as their point of entry. That's a 20% difference in cost. So, I mean, and again, I come back to it, and it also happens to be good medicine. I mean, I've got a primary care doctor. I could refer myself to everybody. Thank God I don't. Half the time I call my primary care doctor, he asks me, did you really graduate medical school?
All right. Let's open it up for some questions. We can certainly take 2 or 3 questions. There's a microphone coming around the room. Please do identify yourself. But do I see a question? Yes, please,
Hi.
Right there in the center.
Good afternoon. My name is Raul Alwani. I wondered if you could comment a bit on the supply of medical practitioners here in the U.S., whether it's at the primary care level or specialized medicine. Are we producing enough? What impact does the school system in terms of producing these practitioners have in terms of the entire healthcare ecosystem? And what impact does that have on the cost of the healthcare marketplace at the end?
So we clearly produce enough doctors. Okay, so on the whole. You could argue a little bit that our distribution has been very specialty heavy, and a lot of that is driven, quite honestly, by economics. People gravitate towards the more profitable subspecialties. The problem, it's I think it was Warren Buffett that told, God forbid I should ever quote Warren Buffett, but I'll do it anyways, that said that when he went to the shoe shine guy and the guy would tell him, oh, I heard this company is really hot, it's time to sell. Same thing happens with specialties, right? Well, by the time they get really hot and they start populating, they've moved away. Perfect example is cardiology, right? There's been a real decrease in the utilization of cardiology in the United States. It's because the statins work. The cholesterol has gotten lowered. Drugs actually worked, oh my God, and stents actually worked. So less people need cardiologists. Now there's a lot of them. So we have enough doctors, whether or not the distribution with primary care, non-primary care is appropriate, you could argue. What you can't argue is that they're not all in the right places, right? So I believe that there's geographically. I believe we have plenty of primary care, especially when you put in the work that's done by nurse practitioners and PAs now. So I think we have plenty of primary care. I just don't think it's always distributed in the right locations for the need.
Let's take another question, please. we have another one? Yes, maybe the lady here on the, over to the right.
Thank you. Hi, my name is Reba. I work in film and TV. I guess I'm not sure if you can speak to this, but I'm curious what you think about medical tourism and why there are so many people leaving this country to get procedures done, even dental procedures, which we should be able to handle that kind of thing. And I did have another question. I was wondering about technology, since we've talked about that a lot, what your organization does to improve that. I just found out recently that my primary care doctor is connected to this Weill Cornell Connect system. I can see everything on my phone. I can email my doctor. I can see my test results. I think it's great. And I'm wondering if that's going to be something we see more of to help people understand what's going on. Thank you.
Sure. So, I mean, I think medical tourism is a reality. I think it's a reality not only outside of the United States, but even inside of the United States. Unfortunately, it really is only a sub-select group of people that are capable of utilizing it. Dental is a little different because dental is not always covered, and even if it's covered, it's 50% or 40%, so people are looking for more cost-effective ways. I think in medicine, large parts of the country that have more all-encompassing insurances cover it all. I think inside the United States, medical tourism tends to be, the wealthy people flying to, Mayo or, some other place for their total body scans and their imaging, their concierge medicine. And I think flying outside of the U.S. is not as prevalent as people think. I think it's an opportunity afforded to maybe not the richest at the top because they don't care, but kind of the upper middle class and with that overlap with bad coverage. So I don't think it's as prevalent. The IT interfacing in healthcare is both a huge opportunity and a huge problem. One of the biggest problem IT has is that a lot of the systems in the U.S. at individual hospitals and even within departments of hospitals and doctors' offices and surgery centers, so I'd say hospitals, but it's really throughout, are homegrown. Or there are different companies that do it. And you have a very hard time getting the data, right? So no one knows, you go into a hospital and you're John Smith, how are they gonna get the data from every other hospital you've been at, every doctor you've been at, most of which have freestanding computers in their offices, and know who's John Smith, where John Smith is? It becomes very difficult to get the data together, and it's been a struggle. As to using IT to interact directly with patients, I think it works great in our demographic, right? But our demographic is not the ones that really consume healthcare. It's back to something my mom, we gave her an answering machine, and every Friday she'd call us and say the light's blinking, and we'd tell her how to retrieve the message. She finally stopped calling. I said, oh, you figured out the answering machine? And she goes, no, I took it off. So people in their later years in life that you really need to kind of manage their care and their disease processes are the ones that least use technology. Medicaid, the poor, are the ones that have technology least accessible to them. So in many ways, our populations that most need the intervention now are the ones that aren't helped by technology.
That's an interesting point. Other questions, please? I think I see one in the back. Yes?
Hi, Jan Rosenquist, emergency physician. Dr. De La Torre, I've got a question for you. I realized you said you think there are enough physicians now, but what I see in the emergency room is I see more and more people coming in saying they can't see their doctor won't see them for whatever reason, and maybe they don't have an opening for 4 months, they don't have, or they won't take their insurance, or they won't do something, or their hours aren't going that late. Do you think that as a group of peers that we could do something better at the office level to try to accommodate these people who maybe don't have true emergency level visits, that maybe we could handle some of that load and contain the costs by still keeping it at the office level instead of people flooding into the ER, because we have very expensive costs and we end up with very redundant costs in the ER because of duplicating a lot of workups and things like that.
So yes, but I want to clarify what I said. I said, do we have enough physicians? Yes, and I fundamentally believe that. Do we have enough physicians within our broken system? No. it's a little bit of, do I have enough gasoline or oil to supply for the United States? Well, yes, if we all drove Priuses. If we all drove 1969 Cadillacs, we're screwed. So it's a little bit of exactly what you said, changing the system, and we do all this. We open up urgent centers, we cross-cover them at night so that patients can go to an urgent center from catchment from various of our primary care doctors. We keep walk-in hours. For patients that don't have primary care doctor, we guarantee them a primary care doctor within 24 hours, a visit within 24 hours. We have a 1-800 number, you call it. Now, you have to understand what that means, though. It means that it can't be, oh, I want to go see Dr. Jones at 9 o'clock in the morning or between 9 and 10. And if you sit down in the cocktail hours, that's what you hear a lot of. People say, you know what, we don't have enough doctors. I try to go see my doctor and they can't see me. Well, be more specific. Well, I wanted to go see Dr. Smith and, Fridays, because that's when I have off, and, and I have to go somewhere at noon. So I try to get an appointment with Dr. Smith between 9 and noon. Well, that's a different question. With a broken system, the way the system is now, you're right, we'll never have enough doctors. But with a better and a more appropriate system, with appropriate urgent care centers, with later hours, with walk-in centers, with better coverage, better use of nurse practitioners and PAs, all of which exist now, then I think we have enough doctors.
Another question, please. Because I think there's a gentleman here at the center.
This is going to sound like a longer question, but it won't be. My insurance agent just retired. She has time on her hands, and she's brilliant. She goes through her Medicare bills. Every month, she gets hundreds, if not $1,000 of procedures that she never had. That she's getting, she's not getting billed for. But she actually takes the time to go through and do this. I don't think most people would do that. Just what are your thoughts on the level of, I don't know if that's fraud or if it's a mistake. If it's error, then the procedure could really be done. It could be a legitimate cost to the government. But it's tempting to think that there's some fraud going on there. Yeah. What are your thoughts?
So when you hear about charges and what we charge Medicare, it's an irrelevant number. Medicare has a DRG basis, and so which is a diagnostic-related group. They pay by a service incident. So you go in, you have heart surgery, for example, they pay an X amount, no matter what the costs are, no matter what you bill them. It's irrelevant what you bill them, you get paid a fixed amount. So that's why when you hear about what people charge and how different hospitals charge differently, it's almost irrelevant. What you really know is how much they actually get paid for their charges. But I think you hit upon a very critical issue, which is, I've got a very different view of healthcare than I did 3 or 4 years ago. I actually think that with pharmacology being what it is, and with just basic care that you read about today, nobody in the future is going to get sick before the age of 65. Very few. So what our employers are doing and what our commercial insurers are doing is basically providing a gap between when patients turn 20 and between 65 of providing health care. So I think it's important, and I was having a debate with one of our senators about this. The real important thing about putting mandates into coverages on the commercial side is that you need to know what you're getting when they turn 65, and we as taxpayers are responsible for them. And I think that's going to play larger and larger into the future.
Right. Well, I think with that, we've just about run out of time, but please join me in thanking Dr. De La Torre for his comments. Thank you very much.
Yeah, thank you.